Hello everyone, good evening. I am Dr. Vyshnavi, your ENT faculty on the PrepLadder platform, and today I am here with the previous year's questions for the FMG students. So before we start the class, I would require a quick confirmation from all of you if I am audible and visible so that we could begin our class. Good evening, Farman. I hope all is okay with on your end and you're able to hear me and listen to me and see me well. Great. So if everything is going on well, so the plan is today we will be doing the 3 years 2020, 2019 and 2018 questions. So we are going to do it in the descending order, and then tomorrow we are going to do 22 and 21 questions. So I have made the 3 years questions, aligned them together in this particular session for today. Tomorrow's session will be on 2021 and 22, so that we will discuss all the 5 years in the 2 sessions. Okay. Dilip, Soni, thank you. I'm good. I hope all of you are doing well as well. Great. So without wasting any time, let's do the 2020 questions of the FMG examination. So I will be teaching you relevant points regarding the options as well. But if you've got anything extra that you'd like to learn, please mention in the chat box. I'll be more than happy to answer all your queries that you need from me from the ENT perspective. Okay, let's get started. A young adult presents with a deformed nose after falling from a ladder. The CT scan is showing a displaced nasal fracture. What is the ideal time to reduce the fracture in this patient? Within 12 hours following the injury, 5 to 7 days following the injury, after 2 weeks of the injury, after 4 weeks of injury. What do you think is the right answer? Okay, so Samir says 1, Fehman says A, Pavi says A. What about others? Okay, so most students are answering as A or 1, but that is not the right answer. The more appropriate, see, now we know that 2 answers will be very close in the examination. Which are those 2 options which are very close? Of course, after 2 weeks and 4 weeks is definitely not going to be the answer, because by that time the reunion would have already started. So we will not try to realign the fracture once there is already bony union happening. So that is never going to be the answer. After 2 weeks, after 15 days is not the answer. Now which one will you choose, 12 hours or 5 to 7 days? The most appropriate time to reduce a fracture will be 5 to 7 days in the nasal bone, because in the initial part or in the first 12 hours of injury there will be swelling or there will be edema, and this swelling or edema will obscure if the cosmetic deformity correction has been done well or not. But by 5th day the edema will come down. By 5th to 7th day the edema will come down, and when you correct the nasal bone deformity, the ability to appreciate cosmetic correction will be much better, and ability for you as a surgeon to achieve cosmetic correction will be much better. You won't do after 10 to 15 days, because already the union between the displaced fragments would have started, so you won't do it later. But before also you won't do, because the swelling will not allow you to see if the correction that you have made is appropriate or not. So which is why the answer will be 5 to 7 days. And again, this is with a reference that I have rechecked, because in some books they do mention 12 hours, but again the recent references do mention the answer to be 5 to 7 days. Now if the same question would have been given to you as if there is a patient who's had a fall from the who's had a fall, and on examination on CT scan there is an undisplaced fracture. So it's not a displaced fracture, there is an undisplaced fracture. So if you have an undisplaced fracture, what would you do? Would you correct the fracture or would you not correct the fracture? What would your treatment be? If it is an undisplaced fracture, unless it is causing any cosmetic abnormality for the patient or unless it's causing any breathing difficulties for the patient, you are not going to correct that fracture and it will heal by itself. So unless it is not displaced, or if it is displaced only, you're going to take it for surgery. Otherwise you can just leave it as it is, it will heal by itself. Okay, so I think that's good enough. Now let's go to the next question. A very simple, easy question, but asked number of times in the examination. Bony septal perforation occurs in leprosy, rhinosporidiosis, syphilis or tuberculosis. I think this is a standard question, fact based question, repeat question, bar bar aata hai. What is this? bony septal perforation occurs in? Very, very good. So if you see septal perforation, most perforation occurs in the cartilaginous portion of the septum, except in syphilis. So syphilis is a condition where you see bony septal perforation occurring. Now whether it is TB, whether it is trauma, whether it is cautery or coagulation, all of them will affect your anterior portion of the septum. So if you see, the perforation will be seen in the anterior portion of the septum, and we know anterior portion of the septum is your cartilaginous portion. So most perforation occurs in the cartilaginous portion of the septum except syphilis, where you will see the bony septum involved. And where do you see total septal perforation? Where would you see total septal perforation? Quickly answer. Total septal perforations are seen in? Very, very good, Dr. RJ. It is seen in vaginous granulomatosis. So in vaginous granulomatosis, you will see total septal perforation. Okay. Yes, Jitendra, cocaine, drug abuse, piercing of the nose, trauma, septoplasty, septal abscesses, all of this can cause septal perforation, but all of them will involve only the cartilaginous portion. Bony septum is involved in syphilis, and total septum is involved in vaginous granulomatosis. Okay, let's do the next question. A young male who is a professional trumpet blower presented with a swelling on the left side of the neck. On examination, there was a gurgling sound on compressing the swelling. As the X-ray was inconclusive, a CT scan was taken. What is the most likely diagnosis? Tracheoesophageal fistula, laryngocele, pharyngeal pouch, tonsillar cyst. Okay, so let me see what is the issue. I'll just ask the team if the video is lagging and if something needs to be done. Okay, so most of you have answered this absolutely right. So what you see here is basically an air-filled cystic swelling. So whenever you have an air-filled swelling, it will appear dark like this. So whenever you have a swelling that is air-filled, it will appear black. So an air-filled cystic swelling on the side of the larynx or in the neck, the most common air-filled swelling is nothing but your laryngocele. So laryngocele is nothing but an air-filled cystic swelling that is present on the side of the neck. Okay, so this image that is shown to you here is specifically talking to you about laryngocele. Okay, just give me 1 minute everyone. I will just check with the team what is the issue and I'll just come back in 1 minute. Where is the mic?
डॉक्टर just please give me a second. डॉक इस पे ग्रीन आ रही है. हेलो.
Where is the mic? I can't see the mic here. Set me to mute the mic.
अच्छा ये हाँ ये
Yeah. Okay, so I guess guys, everything is working well on my end. The team has also checked, and I'm thinking that there is nothing wrong on my end. So, if it is okay now, let me know. Okay, so I think it's fine now, everyone. Okay, so we were discussing about laryngocele. Laryngocele is nothing but an air-filled cystic swelling that we have around the larynx. Basically, this happens because of increased pressure in the saccule of the larynx. Saccule is nothing but a part of the ventricle. Okay. So if it's fine, quickly give me a quick confirmation that it's fine. Let me know quickly if this is all fine, then we can begin the class. Okay, so I guess this is going well, and we can start the class. Okay, so I was discussing about this air-filled swelling, and whenever we have an air-filled swelling, it is because of the dilatation of ventricle, and dilatation of ventricle in the larynx is called as a laryngocele. So if we take the larynx, we have got the thyroid cartilage on the outside. Below the thyroid cartilage, we have the cricoid cartilage. Now we have got a membrane on the intrinsic surface of the larynx, which is called as the quadrangular membrane. The lower fibers of the quadrangular membrane forms the false cords. The upper fibers of the cricovocal membrane will form the true cord. So we have the cricovocal membrane, and the upper fibers of the cricovocal membrane will form the true cords. Now there is a space that is there between the false cords above and the true cords below. This space we call it as the ventricle of the larynx, and from the ventricle you get an elongation. So from the ventricle, what do you get? You get an elongation. This elongation is called as saccule. So whenever there is an increase in the transglottic pressure, like when you're blowing a trumpet, whenever you're blowing balloons, or when you're glass blowers, weightlifters, when the laryngeal pressure will increase, the pressure gets transmitted to the ventricle of the larynx and from there to the saccule, and this becomes a cystic air filled swelling. So this cystic air filled swelling is called as a laryngocele. So you can see on the side of the larynx an air filled cystic swelling in a coronal cut showing you the laryngocele. In an axial cut, this is how it would look like. So you will see this is your thyroid cartilage. On the side of the thyroid cartilage, you are able to visualize that cystic swelling, that is nothing but your laryngocele. Okay, yes. Let's go to the next question. Gold standard investigation before FES. So before you do a functional endoscopic sinus surgery, what is the gold standard investigation? I'm waiting for your answers. MRI or X-ray or antral lavage or a CT scan? Very good. Most of you have answered this right. So the gold standard investigation before functional endoscopic sinus surgery is a plain CT scan. A non-contrast CT scan is the investigation of choice. Now, why is a CT scan the investigation of choice, and why should we do it before FES? You always ask yourself the question why, because you will be able to remember the answers better. So reading between the lines is as important as the line itself when we are talking of investigation of the choice. So when we are doing the FES, first of all, we are operating in an area which is very close to the eyes, very close to the base of skull, very close to major blood vessels. So we need to know our anatomy very well. So before understanding the anatomy, we cannot jump into the surgery, and to understand the anatomy of the nose and paranasal sinuses, the CT scan would definitely be helpful. The second thing is to understand the extent of the disease. How much is the disease present? How extensive is the disease? Has it gone beyond the sinuses? All of that extension can be understood only by a CT scan. So CT scan serves as not only your GPS or your landmark for going to the sinuses and operating safely, but also tells you about the extent of the disease so that your clearance becomes much easier. Okay. Now let's go to the next question. A 65-year-old male presented with a history of dysphagia, halitosis and aspiration pneumonia. A barium swallow was done and it is given, and the image is given below. What is the diagnosis? Is it diffuse esophageal spasm? Is this achalasia cardia? Is this Zenker's diverticulum, or is this esophageal cancer? Again, a very simple question. You can see that there is a pouch coming from the hypopharynx and it is getting filled with the barium, and that is why it is appearing radio opaque on a barium swallow. So what is it? Yes, this is nothing but your Zenker's diverticulum. See, whether it is diffuse esophageal spasm or achalasia cardia, they will typically present to you as a mediastinal pathology, or you will see that corkscrew esophagus in the mediastinum. But when we are talking of the neck, the only pathology that should come to your mind is nothing but your Zenker's diverticulum, which is nothing but outpouching of mucosa through a muscle. Which muscle? Through the inferior constrictor muscle. So inferior constrictor basically has two parts. It has got oblique fibers of thyropharyngeus and it has got horizontal fibers of cricopharyngeus. So oblique fibers of thyropharyngeus and horizontal fibers of your cricopharyngeus. In between them there is an area of dehiscence. This area of dehiscence is called as Killian's dehiscence, and if there is an outpouching of mucosa from this diverticulum, we call it as Zenker's diverticulum. Now, is this a true diverticulum? No, this is not a true diverticulum because it does not contain all the three layers of the pharyngeal wall. It is just the mucosal herniation. The muscle, the pharyngo and buccopharyngeal fascia are not herniating. So this is not a true diverticulum. This is a false or a pseudo diverticulum. They typically present to you with dysphagia. They present to you with gurgling sound in the neck. They present to you with sleep cough and aspiration pneumonia. These are all the symptoms that you see, and typically seen in old age because the muscles of the pharynx, the thyropharyngeus and cricopharyngeus, become weak at that age. Okay, Now this is a question which is a standard famous question that comes again and again each consecutive year, and you cannot afford to miss this question. So what is this? Identify the marked structure in the endoscopic image of the nasopharynx. Is this sinus of Morgagni? Is this passavant's ridge? Is this fossa of Rosenmuller? Or is this Rathke's pouch? See, you can see there is a structure that has been marked over here. Can you tell me what is this? So the first structure that you see here, this is nothing but your eustachian tubal opening. Behind the eustachian tube, you see there is a cushion. This cushion is that of the torus tubarius. Okay, this is your torus tubarius. Behind that there is a fossa. This fossa is called as fossa of Rosenmuller. Fossa of Rosenmuller is the most common site for origin of, can you tell me quickly in the chat box, fossa of Rosenmuller is the most common site for origin of what? Very good. Quick guys. Most common site of origin for? Yes, very good. It is the most common site of origin for nasopharyngeal carcinoma. So I think this is understood very easily by all of you. So the correct answer is, the structure that you see is fossa of Rosenmuller. Now what is sinus of Morgagni? Can anybody tell me? Now in the pharynx we have got the base of skull superiorly, and we have got three constrictors. We have the superior constrictor, middle constrictor and inferior constrictor. Now there is a space that is present here between the base of skull above and the superior constrictor. So this space is called as sinus of Morgagni, or also called as gateway of tears. So here you have the space between the base of skull and your superior constrictor. This space is called as sinus of Morgagni. Okay, what is passavant's ridge? Between the nasopharynx and the oropharynx there is a ridge which will contract and relax, especially during swallowing, preventing nasal regurgitation. That ridge is called as passavant's ridge. Passavant's ridge is formed by the fibers of palatopharyngeus muscle. So the palatopharyngeus muscle, the fibers of this muscle form the passavant's ridge. Okay. So I think this is clearly understood by everybody. Let's go to the next question. That is a little difficult, but I think you should be able to answer. A patient presents with carcinoma in the pyriform fossa. On laryngoscopy, the lesion is around 5 centimeters and the right vocal cord is not mobile. There is no lymph node involvement or no distant metastasis. What is the TNM staging? See, TNM staging, they have clearly said no lymph node, no metastasis. So you see all the options are N0, M0, N0, M0. Now you have to decide only the T stage to get to the right answer. So can you tell me what is the T stage? Okay, so whenever we are talking about pyriform fossa, it comes under the carcinomas of the hypopharynx. So when we talk of carcinoma of the hypopharynx, when we talk about the T stage of the tumor, basically we divide it on the size of the tumor, on the subsite that has been involved, and if or not there has been fixation of larynx. So these are the three parameters that we will take into consideration when we want to do the T staging of the tumor. So if the tumor is less than 2 centimeters in size, so maximum size is 2 centimeter, then you will call it as T1. And here there is no involvement of the larynx or fixation of the larynx. Okay, that is T1. Now if it is between 2 to 4 centimeters, it is going to be T2. So T2 is involvement of the hypopharynx more than one subsite, meaning from the pyriform fossa it can go to postcricoid, from pyriform fossa it can go to posterior pharyngeal wall, and here also there is without fixation of the hemilarynx. Phalarynx has not yet got fixed, indicating there is no infiltration of the larynx. That is T2. What is T3 then? If it is more than 4 centimeters, involving more than one site, and if it is involving the larynx, causing fixation of the larynx, then you call it as T3. So if you have all these three parameters, then it is going to be T3. If there is a local spread to the adjacent structures like the hyoid bone, the thyroid gland and the soft tissue of the neck, it is going to be T4A. So T4A is going to be locally advanced disease, but T4B is going to be extensively advanced disease where it involves the prevertebral fascia and encases the carotid artery. So I think 4A and 4B usually they won't ask you, they will ask you either between T2 or T3, because T1 is relatively simple, involving less than one subsite, vocal cords or larynx is not involved, and less than 2 centimeters. I think everyone will know that the questions will come mainly on T2 and T3. So 2 to 4 centimeter, no involvement of larynx but involvement of more than one subsite is T2. Involvement of larynx, more than one subsite, more than 4 centimeter is your T3. So I think this is clear now. What is T1, what is T2, what is T3 in the carcinomas of the hypopharynx? Yes. Now let's go to the easier question. So if we go to the answer, we know that this is a 5 centimeter lesion, meaning more than 4 centimeter comes under T3. There is involvement of the vocal cord, they are not mobile, so fixation is there, so you will take this as T3. So the correct answer is T3, N0 and M0. Okay, so I hope everyone got the right answer. Let's go to the next question. In which of the following condition reservoir sign is seen along with mastoid tenderness? Otosclerotic lesion, acute mastoiditis, intratympanic glomus tumor, CSO. Again a very easy question. Reservoir sign is one specific sign. Again a constant repeat in every examination. You are seeing this coming again and again. When you see reservoir sign, something has to stick to you. Very good, all of you have answered this right. It along with mastoid tenderness, if you get reservoir sign positive, you must think about acute mastoiditis. So what is reservoir sign? Basically when we have a patient who has mastoiditis, there will be pus that comes out of the tympanic membrane. It comes in a pulsatile form. So you will see that there is a hole and pus comes out in a pulsatile form. Now if I mop the pus, I clean up, or if I mop the pus, if there is an immediate recurrence of pus, meaning after you have mopped, immediately the pus comes out into the canal, it indicates that there is a patient who is having mastoiditis. But if it is ASOM only, where there is only middle ear disease and not mastoid disease, there will not be immediate recurrence. But if there is a mastoid disease, the pus will be pushed to the middle ear, and from the middle ear it will come to the external auditory canal immediately, telling to you that in acute mastoiditis reservoir sign is positive. Now in otosclerosis there is a clinical sign. Can anybody tell me where you see a flamingo pink appearance of the promontory seen through an intact tympanic membrane, seen in an active lesion? What is that sign called as? Starts with S. Yes, very good. That sign is called as Schwartz sign. So Schwartz sign is a clinical sign that you see in otosclerosis. Now in glomus tumor, again you see one very important sign where you see a red reflex behind an intact tympanic membrane. Can anyone tell me what is this sign called as? A red reflex behind an intact tympanic membrane. Very, very good. Paras, Tejamul, Radhesham, very good. Very, very good. This sign that we see here in glomus, where you see a red reflex behind the intact tympanic membrane, we call that as a rising sun appearance. Sometimes it is also called as sunset appearance. Now on seagulization, if I increase the pressure in the external auditory canal, the pressure gets transmitted to the tumor, it vibrates vigorously and then becomes pale. That sign is called as Brown sign. So on seagulization, the pressure gets transmitted to the tumor vibrates vigorously and then becomes pale. That sign is called as Brown sign. So the clinical sign that you see in glomus is sunset appearance and Brown sign. Schwartz sign is seen in otosclerosis. CSOM typically, whether it is tubotympanic or atticoantral, you will see the perforations. In tubotympanic you will see a central perforation, atticoantral you will see a attic perforation. So these are all the important signs that you should know for a patient with otosclerosis or mastoiditis or glomus or CSOM. Okay, great. So I think everyone has understood that. Now let's go to the next question. Which of the following statement amongst the following for the given condition is false? Amongst the given options is false. You have to type. Is this a retention cyst of the major salivary gland? The most common site is lower lip. Retention cyst of the minor salivary gland. Treatment is surgical excision. So which statement is false is the question. I'm waiting for your answers again. See, basically you see there is a sort of a swelling, a mucus retained swelling, and is this coming from your major salivary gland or minor salivary gland is the question that you have to understand. See, most common site for this is definitely going to be the lower lip. This is true. And treatment is surgical excision. So basically what you are seeing here is nothing but a mucocele of minor salivary glands. So whenever there is an extravasation of the saliva from these minor salivary gland, either because of trauma or either because of infection, there will be accumulation of that mucus within those salivary gland, resulting in this swelling, and they come from these minor salivary glands which is present in the lips, which is present in the buccal mucosa, which is present in the palate. But amongst the site where this can occur, the most common site is definitely your lower lip, and they are known to resolve spontaneously. But if they do not resolve spontaneously, then the treatment will be surgical excision. But are they retention cyst of your major salivary gland? Absolutely not. Major salivary glands are your parotid, submandibular and sublingual salivary gland, and they present to you very differently. Parotid will present to you as a swelling here, submandibular and sublingual will present to you as a swelling in the floor of mouth. So this cannot be of the major glands, but this is definitely of the minor glands. Okay, so I hope you understood what is the false statement here. Okay, now let's go to the next question. A patient presents with hoarseness of voice. On examination, an ulceroproliferative mass is seen on the right vocal cord. Cord was however mobile. So please see, there is involvement of which cord? Only right vocal cord, and the vocal cord is mobile. There is no lymph node involvement and there is no metastasis. Which of the following is the best modality of treatment for this patient? Is this total laryngectomy, radiotherapy, conservative laryngectomy or chemotherapy? Now this is a very easy question. See, some of you mentioning it as 3, some of you mentioning it as 2. Now first of all, if I have to draw this image to you of what has been described, what has been described to you, they are telling to you that there is an ulceroproliferative mass on the right vocal cord. So there is a lesion on the right vocal cord over here, and this ulceroproliferative mass is only on the right cord. They have not told you about the size or anything of that. They have told you vocal cord is mobile. Okay, so what is the T stage of this patient? So whenever we talk of laryngeal carcinomas TNM classification, we have T1, T2, T3, T4A, T4B as the main indicators for your T staging. So what is T1? If the tumor is involving only one subsite of the larynx. What is one subsite of the larynx? It can involve either the glottis, it can involve the supraglottis, or it can involve the subglottis. Only one subsite, we call it as T1. So involvement of one subsite of the larynx is T1. Here the vocal cords are mobile. There is no fixation of the cord. This is the root. T2, it is more than one subsite of the larynx. meaning it can go from the glottis to the supraglottis, from the glottis to the subglottis. So it is involving more than one subsite. Here the vocal cord may be mobile or it can be partially restricted in its mobility. It is not fixed, but it can be fully mobile or partially mobile, but we are not saying that it is fixed mobility. That is your T2. What is T3? 3 means, remember, 3 rules are there. It is definitely involving more than one subsite of the larynx, but here the vocal cord is fixed. There is involvement of spaces of the larynx. And the third rule is it should involve the inner perichondrium of your thyroid cartilage, not the outer perichondrium, inner perichondrium. So if I take this as the thyroid cartilage, it should involve the inner perichondrium, not the outer perichondrium. Then it is T3. What is T4A? Local spread to the strap muscles, to the hypopharynx, to the lower trachea, to the base of tongue. That is all 4A. 4B is distant spread, like carotid involvement, prevertebral space involvement, mediastinal involvement. That is T4B. Now our question is saying us that there is a patient who is having a carcinoma of the right vocal cord. There is an ulceroproliferative lesion on the right vocal cord. Vocal cord is mobile. So how many sites has it involved? Only one side. They didn't say it is going to the epiglottis, it is going to the subglottis. They didn't say any of that. So involving one side, and they said vocal cord is mobile. So our patient is falling in which category? Our patient is falling in T1 category. They said there is no lymph node involvement and there is no distant metastasis. So if we go back to the question, right vocal cord, no lymph node involvement, no metastasis. So patient is T1, N0, M0. So if there is a patient who is in T1, N0, M0, we will stage this as stage 1. Do you all know staging, or should I give you a quick easy shortcut for staging? If yes, quickly mention in the chat box that you want me to teach you the staging before we go to the treatment. If you know it, fine, I'll go to the treatment. If you don't know and if you want me to give you a quick shortcut, I'll go to the staging. Quickly let me know in the chat box, what do you want? Yes, great. So basically when you are asked to stage a laryngeal carcinoma, write like this: stage 1, stage 2, stage 3, 4A, 4B and 4C. Now whatever number is there on the stage, add to the corresponding T, like T1, N0, M0, stage 2, T2, N0, M0, stage 3, T3, N0, M0, stage 4A, T4A, N0, M0, 4B is going to be T4B, N0, M0 and 4C is going to be T4C, N0, M0. Now everyone must be telling, what ma'am, it can't be so simple, it can't be that easy, you're just bluffing us. Yeah, it can't be so simple. Now we will add to this knowledge that we have. Till here it was easy. Now leave stage 1 and stage 2, they are as it is. Okay, so this is as it is. Clear? This is as it is. Now what is stage 3? It can be T1, it can be T2 or it can be T3. But what is happening to end stage? N0 becomes N1, M0. So whenever you have a lymph node that is N1, then the answer will be stage 3. Got it? So it can be T3, N0, M0 or T1, T2, T3, N1. M0. For example, if there is a patient who is T2, N0, M0, I will say he is stage 2 disease. But if I have a patient T2, N1, M0, then what will the patient stage be? Absolutely right. Now the stage shifts to stage 3. Got it? So easy. Now tell me what should be 4A then? Stage 4A, it can be T1, T2, T3, T4A, but N1 becomes N2, M0. And what will 4B be? It can be T1, T2, T3, 4A, 4B, but N2 becomes N3, M0. And what is 4C? It can be any T, it can be any N, but M1. So as we see, each stage, stage 3 to 4A is by N2. 4A to 4B is by N3 and M1 is your 4C. So now is your TNM staging very easy, everyone? I hope everyone understood this. It's made simple. So now you know T staging, you know about how to stage the lesions. Now you need to know about the treatment for each stage. I am presuming everyone knows the N classification. If you don't know, quickly one quick shortcut: N1 less than 3 centimeter node, N2 3 to 6 centimeter node, and N3 is more than 6 centimeter node. This is general classification, but if you want I can elaborate and give you a quick shortcut for those of you who want even the N classification. M0 is no distinct metastasis and M1 is distant metastasis. Okay, so I think by now you all are very clear about the T staging, N staging and M staging of laryngeal carcinomas. Yes, so now let us go to what is the treatment. The treatment for stage 1 and stage 2. Let me add a slide, just give me one moment. Yes, so if there is a patient who is lying in stage 1 and stage 2, so treatment for laryngeal carcinoma, if the patient is in stage 1 or stage 2, if the patient is having the tumor for the first time, we call it as primary. Okay, and if the patient is having recurrence, meaning he's already undergone a treatment for carcinoma prior of the larynx and now he's coming in stage 1 and stage 2 recurrence, the treatment will change. Okay, this is a general rule to just apply for your examination. Don't apply it for your real life patients, because in a real life we go to a tumor board and decide the line of management based on various factors, but this is just a quick simple shortcut for your exams. Okay, so if there's a patient with stage 1 and stage 2 primary carcinoma, the treatment of choice will be RT, radiation therapy. There is one exception to this rule. The exception to this rule is if the patient is having carcinoma of the middle third of the larynx. Okay, so carcinoma of the middle 1/3 of the larynx, where you will prefer to do a microlaryngeal surgery. Okay, as if I'll do the end staging after this. Okay, just to get you all on the track, I'm going to teach you treatment first, then we'll go to the end staging. Okay, so RT will be the treatment of choice for all the primary lesions except the carcinoma of the middle third, where you're trying to do your microlaryngeal surgery. This is for primary, meaning the first timers. Repeaters, all those who come to you with repeat carcinoma and they're in stage 1 and stage 2, here you're going to do conservative laryngectomy, conservative or partial, not complete, but you're going to do partial laryngectomy. So this will be for your recurrence. This question will usually not come, but I'm just telling it to you for your understanding. Okay, now if you have a patient with stage 3 or early 4A, and if the patient is primary carcinoma, first timer but in 3 or 4A, what will you do? You will do chemo RT. Okay, there is again an exception to this rule. Now if there is a patient who is having carcinoma of the epiglottis, say this is the epiglottis, and there is pre-epiglottic space involvement. It is involved because of the proximity to the epiglottis, right? But once the space is involved, we classify it as T3. So here we are not having fixation of the cord, we are not having involvement of the inner perichondrium, but just because the space got involved, we label T3. So except for this patient, like a carcinoma of the epiglottis with involvement of pre-epiglottic space, except for this patient, all the T3 lesions or stage 3 lesions, you will give chemo RT. For this, you are going to do a partial laryngectomy, a supraglottic laryngectomy. You don't have to know the words, you just have to remember partial laryngectomy. Now, if you have a patient who is in a recurrence in stage 3 and 4A, you will go for total laryngectomy. Okay, so this is the treatment protocol in general for a patient with carcinoma of the larynx. Again, there are many things that we consider, but this as a general rule I have explained to you, that when there is an MCQ, how you will target your question. Now our question typically mentioned stage 1 and they typically mentioned to you that this was a primary lesion. So stage 1 primary lesion, what will you do? The answer will be RT. So the answer for our question is going to be radiation therapy. Now, why am I not choosing partial laryngectomy or conservative laryngectomy or chemotherapy? Because this is a stage 1 lesion. They haven't even mentioned about the location. Is it in the anterior third, middle third, or posterior third? So if they had mentioned middle third, I would probably choose conservative laryngectomy, but that is not mentioned. So we are going to take radiation therapy as our answer. So I hope everyone knows the T staging. One subside vocal cord normal, T1. More than one subside vocal cord normal or partially mobility, T2. More than one subside vocal cord fixed spaces are involved, inner pericordium is involved, T3A. Local spread T4A, distant spread T4B. And you know the TNM staging, N1 is stage 3, N2 is 4A, N3 is 4B, any T, any N, but M1 is 4C. Okay, so a quick recall for the N classification for a few of you who were asking. So basically N0 means there is no neck node. So whenever there is no neck node involvement, you will call it as N0. If N1, the neck node is less than 3 centimeters in size, you call it as N1. N2 is 3 to 6 centimeters in size, and N3 is more than 6 centimeters in size. Now N2 is further subdivided into 2A, 2B and 2C. Now the easiest way to remember this is A is your first alphabet, right? So when we say 1 or first, do we mean single? Yes. And whenever I say 1, can I write 1 as like this, Roman digit number 1? Does it resemble I? Yes. So single ipsilateral node 3 to 6 centimeters in size is N2A. As simple as that. What is B? Second alphabet. So second alphabet means more than one, so it will be multiple. Okay, so multiple, but if they are ipsilateral nodes between 3 to 6 centimeters in size, it is N2B. And what does C stand for? C is for contralateral, single or multiple, but if there is a contralateral node 3 to 6 centimeter, then it is N3C, N2C, sorry. Everyone understood now? Easy way to recall. Now N3 is further subdivided into 3A and 3B. There is 3A is there is no extra nodal spread, meaning outside the lymph node there is no spread. But 3B is there is an extra nodal spread. So I hope, Asif, I solved your question and your doubt. Okay, so I think this was a big discussion on the carcinoma of larynx, but a very important question I feel, and all of you I'm sure are going to benefit this and recall this for your examination. Great. Now let's go to the next question. The most common site of obstruction by a nasal polyp from the maxillary sinus is inferior meatus, superior meatus, middle meatus, sphenoethmoidal recess. So what is the most common site of obstruction by a nasal polyp which is coming from the maxillary sinus? As simple as that. You should know where does the maxillary sinus drain, then you will know the answer for this question. Excellent, all of you are absolutely right. The correct answer is middle meatus of the nose. So if I take you to the drainage of the sinuses, if I take this as the nose and if I take this as the lateral wall of the nose, in the lateral wall we have got 3 turbinates. Corresponding to the turbinates we have the meatus. So can you tell me what opens in the inferior meatus of the nose? The inferior meatus receives the opening of nasolacrimal duct. The middle meatus receives the opening of anterior group of sinuses. The anterior group of sinuses are frontal, maxillary and anterior ethmoids. So if there is a maxillary sinus polyp, it will definitely obstruct your middle meatus. The superior meatus receives the drainage of the posterior ethmoid sinuses. And your sphenoid sinus drains into which recess? It drains into the sphenoethmoidal recess. Again, this is a very important question to know what structures open in what meatus. They are quite often asked in your FMGE examination. Okay, now let's go to the next question. Laryngeal crepitus is absent in all of the following except. So in which condition laryngeal crepitus is not absent? So can you tell me? It is absent in all of the following except. Okay, so let me explain to you what is laryngeal crepitus. So basically laryngeal crepitus is a method of examination where we are trying to glide the larynx against the vertebra. So you hold between the thumb and the index finger and try to glide the larynx against the vertebra. So when we are trying to elicit the laryngeal crepitus, we are usually pushing the cricoid cartilage against the vertebra. So what will we do? We will push which cartilage? The cricoid cartilage. So we will push it posteriorly and glide it side by side. So if there is any pathology, like say there is a pyriform fossa tumor, or there is a hypopharyngeal mass, post-cricoid malignancy, retropharyngeal abscess, or a prevertebral abscess, can I glide the larynx easily against the vertebra and get that click sound? No. So that sign where there is absence of laryngeal crepitus. So whenever there is absence of laryngeal crepitus, we call that as Moore's sign positive. So normally everyone should have this laryngeal crepitus present. But if there is an absence of laryngeal crepitus, then we say that the Moore sign is positive. Yes, so that is called as absence of laryngeal crepitus. We call it as Moore sign positive. So it is absent in post-cricoid malignancy, hypopharyngeal abscess, prevertebral abscess, but not absent in parapharyngeal abscess. So I think there is a lag. It will be fine. Just give me one moment. It will be fine. Okay, so fine. Now let's go to the next question. All the following are true about BERA, brainstem evoked response audiometry. Which of the following is true? It can be used for screening of hearing loss. It is an invasive procedure. It can be used for assessing neonatal hearing loss. It is a subjective investigation. So answer in the chat box. What is true about the statements that has been given? So is it used for screening for hearing loss? Is it an invasive procedure? Is it used for assessing sensory neural hearing loss? It is a subjective investigation. So which statement is true? Yes. So whenever we are talking about BERA or brainstem evoked response audiometry, this is a procedure where on a child's head or forehead we will put an electrode. On the child's ears we are going to put some electrode. We are going to give an auditory impulse or a sound stimulus, and whenever there is a sound stimulus, there is some electrical activity happening in the brainstem. That electrical activity is recorded in the form of graphs, which we call it as BERA. So are we going inside the brain to do some investigation? No. So this is an invasive or non-invasive test. This is a non-invasive test. So this is option is false. We are not going inside the brainstem to do the test. So this is not invasive test. Is this used for screening? No. The investigation of choice for screening is otoacoustic emission. BERA is confirmatory. So BERA is always used for confirmation of hearing loss. It is not used for screening of hearing loss. So this statement is also false because the screening investigation of choice is otoacoustic investigation. Now, is this a subjective investigation where the patient can give a response? No, the child is made to fall asleep and the child doesn't give a response. There's a machine that's giving response. So this is an objective investigation. This is not a subjective investigation. But is it used to assess sensory neural hearing loss? Yes. This is a test that objectively evaluates your retrocochlear pathway. So basically your sensory neural pathway has two pathways. It has got a cochlear pathway and a retrocochlear pathway, which is your E. coli. So this investigation basically tests your retrocochlear pathway, your E. coli. So I hope everyone got it. This is not used for screening. It is not invasive. It is not a subjective, but it is an objective test. It is used for assessing sensory neural hearing loss, typically the retrocochlear pathway. So in BERA, you are going to get 7 waves. Each wave represents one part of the auditory pathway. So from the cochlea to the brainstem. Brainstem consists of cochlear nucleus, superior olivary complex, lateral lemniscus and inferior colliculus. So from there the impulses is carried via the cochlear nerve. This cochlear nerve is containing 2 parts, a distal part which is far from the brainstem and a proximal part which is close from the brainstem. So whenever we give a sound stimulus, the sound travels through the cochlea and first goes to the distal part of the cochlea. So wave 1 comes from which part of the cochlear nerve? From the distal part of the cochlear nerve. It's not E. coli giving mafia, it is E. coli. So first wave comes from distal part of cochlear nerve. Wave 2 comes from which part? Now the sound goes to which part of the cochlear nerve? Proximal part. So wave 2 comes from proximal part of cochlear nerve. So wave 1 and wave 2 are basically from your cochlear nerve. The only difference is wave 1 comes from the distal part, wave 2 comes from your proximal part. Wave 3 comes from where? Wave 3 comes from your superior olivary complex. Wave 4 comes from your lateral lemniscus. Okay. Wave 5 comes from cochlear nerve, then it goes to cochlear nucleus, then superior olivary complex, then lateral lemniscus. 6th and 7th come from your inferior colliculus. So the mnemonic is E. coli. Okay. So 8th nerve, cochlear nucleus, superior olivary complex, lateral lemniscus, inferior colliculus. Okay. Yes. So I hope everybody understood. The mnemonic is E. coli. So wave 1 from proximal part, wave 2 from distal part of the 8th nerve, wave 1 from the distal part of the 8th nerve, wave 2 from cochlear part of the 8th nerve, wave 3 from the cochlear nucleus, wave 4 from superior olivary complex, wave 5 from lateral lemniscus, 6th and 7th from inferior colliculus. Okay, so let's go to the next question. A housewife presents with complaints of blockade of nose, loss of smell, greenish discharge and crusty discharge. On examination, nasal cavity appear roomy and the turbinates are atrophied. Which of the following surgeries can be done on this patient? Submucous resection, Young's operation, septoplasty or videoneurectomy? Yes, Asif, this video will be available on YouTube after the class. Don't have to worry. Whenever you want to revisit, you can always revisit for further references. Yes. So we have a next question where we're discussing that a housewife complains of a blocked nose, loss of smell, greenish dry crusty discharge. On examination, nasal cavity appear roomy and the turbinates are atrophied. What does this diagnosis tell you? The diagnosis is that of atrophic rhinitis. So in atrophic rhinitis, what are we going to do if the medical management fails? So basically you are going to give alkaline nasal douching solution first. That will be your first treatment that you will start off with. What is alkaline nasal douching solution? Sodium chloride, sodium bicarbonate, which is your baking soda, and your sodium biborate. You mix it in water and ask the patient to flush the nose with this solution. If this fails, then you can do Young's operation or modified Young's operation, or you can do Lawton-Slager's operation. These are the names that we use for operations with atrophic rhinitis. For submucous resection, the indication is deviated nasal septum. Septoplasty, also the indication is deviated nasal septum with symptoms. Videoneurectomy is done for non-allergic rhinitis that has failed medical therapy. Then you can do videoneurectomy. So I think I have made you all understand about that question. Okay, now let's go to the next question. The 23-year-old male presents to you with a nasal discharge which has the following appearance on a handkerchief. Again, a repeat common constant question. Presence of which of the following features will help you in diagnosing the condition as CSF rhinorrhea? Halo sign, handkerchief sign, Schwartz sign or Phelps sign. What sign are you seeing here and what does this tell you? There's a specific name given to this. This is seen typically in a patient with traumatic CSF rhinorrhea when there is CSF blood with CSF mixed with blood. So you will see that there is a red dot surrounded by a peripheral halo. This sign is called as halo sign. It is also called as target sign. It is also called as double ring sign. All of them are suggestive of CSF rhinorrhea only. So whenever you have a doubt that is this patient having CSF rhinorrhea or not, you can diagnose with this halo sign. Handkerchief sign is also used for diagnosing CSF rhinorrhea, where you ask the patient to collect the nasal discharge on a handkerchief. If it is fluid from the nose, it will stiffen the handkerchief, but if it is CSF, it will not stiffen the handkerchief. But this is not the sign that you see here. So this is also a sign for CSF rhinorrhea, but not depictive of the image. Schwartz sign we know is seen in otosclerosis, and Phelps sign is seen a radiological sign that you see in patient with glomus tumor. So on a CT scan you will see this Phelps sign in patient with glomus tumor. Okay, so great. I think everyone knows it. Now let's go to the next question. A 5-year-old girl is brought to you by her mother with complaints of mouth breathing. She also complains of flat, expressionless, long face and an open mouth. On examination, there is a high arched palate, crowding of the teeth. X-ray is given below. What is the diagnosis? So you see the age is given. They are telling you mouth breathing. They are telling you expressionless face, crowding of the teeth, high arched palate. What is it all suggestive to you of? Even if you don't know the X-ray, you can't read the X-ray, all this is suggestive to you of a facies. What is that facies called as? Yes, what is that facies called as? Very, very good. This facies is nothing but your adenoid facies. Adenoid facies happens whenever there is an adenoid hypertrophy. So if you take a X-ray lateral view of the nasopharynx, you will be able to see the adenoid in the nasopharynx. So this soft tissue that you see is that of the adenoid. So this is the adenoid hypertrophy. Now how do you grade this? You take an imaginary line passing through the base of the skull and an imaginary line passing through the palate. Now you divide this space into 4 tables, each compartment occupying 25% of the airway space. Now you can see the soft tissue is occupying almost 75% of the space. So this is going to be a grade 3 adenoid. So this is how you are going to answer, and this is suggestive to you of adenoid hypertrophy. Okay, good. Now let's go to the next question. What clinical test is depicted in the image? Is this Epley's maneuver? Is this Heimlich's maneuver? Is this Cottel's test? Or is this Trotter's triad? A very simple test where you ask the patient to breathe in, breathe out. Then you pull the cheek away, ask the patient again to breathe in and breathe out. So what is that test where you see if there is an improvement in the breathing on pulling the cheek away, seen in patients where the deviated nasal septum is obstructing the nasal valve. So to understand or to make sure if the nasal valve is competent or not, what is this test called as? The test that assures you the competency or patency of the internal nasal valve. What is this test called as? Excellent, all of you. This test is called as Cottel's test, and this test helps you understand the patency of the internal nasal valve, especially done in patients with deviated nasal septum. For those of you who do not know what is internal nasal valve is bounded medially by the septum. Superiorly, it is bounded by lower border of the upper lateral cartilage and laterally by the inferior turbinate. So this angle that you see here, this is called as internal nasal valve. Okay, So this is about the internal nasal valve. The angle formed by the internal nasal valve is 10 to 15 degrees. So the angle here is 10 to 15 degrees. So if I have a deviated septum like this, is it not going to compromise the valve? Yes, and it's going to cause nasal obstruction. And there is another very important point for this internal nasal valve. This is the narrowest portion of the nasal cavity. So internal nasal valve is the narrowest portion of your nasal cavity. Now that you understood this test, let's quickly understand what are the other tests. Epley's maneuver is the treatment maneuver that you do for BPPV. The diagnostic maneuver that you do for BPPV is called as Dix-Hallpike maneuver, but the treatment maneuver that you do is called as Epley's maneuver. Hemlitz's maneuver is done whenever there is a foreign body in the airway causing partial obstruction. So the patient is held from behind and given compressions on the xephisternum to push the foreign body out. So that's an emergency airway management procedure. Trotter's method is done in patient with epistaxis, where you pinch the nose and ask the patient to bend forward. That method is called as Trotter's method. So I hope all of them are clear to you. Yes, Paras Patel, surely I will explain to you the innervation of vocal cord once we are done with this class, okay, at the end of the class. Now a child is brought to you with complaints of noisy breathing. On examination you see that there is an inspiratory stridor. Laryngeal examination is given below. You can see the shape of the epiglottis as somewhat like this. It is curled up on itself. So what is the diagnosis? Is this vocal cord paralysis? Is this subglottic stenosis? Is this laryngeal papilloma, or is this laryngomalacia? Yes, all of you? I am waiting for the answer. A very simple, easy question. Whenever you see an omega shaped epiglottis, whenever you get the history of a child presenting to you with inspiratory stridor, the most common congenital anomaly presenting to you with all of this, absolutely right, all of you, the answer is going to be laryngomalacia. From ENT the questions are always very, very simple. The questions will always come from most of the previous year's topic, so don't have to get confused with these questions. These are definitely something that you can expect. So whenever you hear the word inspiratory stridor in an infant or a child with an omega shaped epiglottis, then you must think about the most common congenital anomaly, that is your laryngomalacia. Now vocal cord paralysis, depending upon RLN paralysis or SLN paralysis, you will have the position. Whenever the recurrent laryngeal nerve has got paralyzed, the vocal cord will lie in midline position. But whenever there is an SLN paralysis, the vocal cords will be in abducted position. So this is what you have to remember. Okay, one important takeaway for those students who want to have little extra information: in patients with Arnold-Chiari malformation, so in patients with Arnold-Chiari malformation, they have congenital vocal cord paralysis. So you can remember congenital vocal cord paralysis is associated with which malformation? Arnold-Chiari malformation. Now subglottic stenosis is a condition where you see below the level of vocal cord. So what are you seeing? There is a stenosis or narrowing. So if there is a narrowing or stenosis below the level of vocal cord, this is called as subglottic stenosis. Now if you have got a papillated finger-like projectile lesion on the vocal cord, this is suggestive to you of laryngeal papilloma. The papillomas are usually caused by HPV 6 and HPV 11. There are two types: juvenile onset papillomas, which are often seen in younger age group, where you see multiple papillomas occurring in multiple subsites of the larynx and usually seen due to vaginal birth. Whereas adult onset papillomas are usually seen in older individuals. It is a single papilloma and happens due to sexual transmission. So all these are very, very important. Typically HPV 6 and 11 you have to know about laryngeal papillomas. Okay. Now let us go to the next question. Again, a very common question, a question that is often a repeat. I always say when you are learning pharynx, you cannot go to the exam hall without learning angiofibroma and nasopharyngeal carcinoma. These are like your staple food, rice and chapati that you have to eat every day. Like that, remember this every day. So a 14-year-old boy who is a football player comes to you with complaints of epistaxis while playing football on the ground. There is no history of trauma or a fall. He also gives a history of recurrent spontaneous nasal bleeding. So this is very important. So you see 14-year-old boy is complaining to you of epistaxis, no history of trauma or no history of fall, and this is spontaneous bleeding and this is unilateral nasal obstruction. Contrast CT is showing to you a specific finding. What is this sign where you see anterior bowing of the posterior wall of the maxillary sinus? Yes. So this sign where you see anterior bowing of posterior wall of maxillary sinus, this is given a name. This sign is called as Hallman-Miller sign. Very good. Everyone I'm seeing is answering this rightly. But there is also another sign where there is an increase in the gap between the maxilla and the mandible. So that sign is called as Hondiusa sign. So what is Hondiusa sign? There is an increase in the gap or distance between maxilla and mandible. This is also another radiological sign that you see in patients with juvenile nasopharyngeal angiofibroma. So the history, the image is suggestive to you of JNA. Aquinose sign is a clinical sign seen in patients with glomus tumor. On compression of the carotid in glomus, the tumor becomes pale. That sign is called as Aquinose sign. Teardrop sign is a sign that you see typically on radiology whenever there is a fracture of the floor of orbit. So the orbital contents will now herniate into the maxillary sinus and resembles a teardrop. So that sign is called as teardrop sign. There is nothing called as a hanging drop sign, just to confuse you they have given, but the answer for this question is going to be Hallman-Miller sign. So I think that's understood, but quickly for all those who want me to quickly make you understand about JNA, some important pointers. First and foremost, it is the most common benign tumor of the nasopharynx. So it's the most common benign tumor of the nasopharynx. Second of all, seen in juvenile age group, presents to you most commonly with the origin of the tumor from the sphenopalatine foramen. This is a tumor that occurs exclusively in males, never occurs in females. This tumor presents to you with three main clinical symptoms: bleeding, obstruction and cranial nerve palsies. The bleeding is recurrent, unprovoked, profuse epistaxis. So profuse bleeding is seen because the blood vessels lack something. So the blood vessels lack the smooth muscle layer and hence they bleed profusely. Obstruction, there is a deformity called as the frog face deformity and there is eustachian tubal obstruction resulting in unilateral SOM. The cranial nerves that are involved are 2, 3, 4, 5 and 6. Now how do you diagnose? Contrast enhanced CT scan is the investigation of choice. MRI angiography are done. The main feeding vessel to the tumor, what is the most common feeder to the tumor? It is the internal maxillary artery. So what will you do? You will embolize and block that feeding vessel and the treatment is embolization followed by surgical excision. So these are all important key pointers that you should know definitely about JNA. Now on CECT or an X-ray, I have already told you the sign, Hallman-Miller sign and Hondiusa sign. These are the two signs that you should know. So this should be your last minute important pointers before you go to the exam. Okay, let's go to the next question. A middle-aged man presents with the following lesion on his face. He has a history of acne rosacea. I think this everyone will know. I don't even have to discuss this question. This is something like a cakewalk for all of you. Yes, Tajamul, the biopsy, FNAC, probe test, digital palpation, all are contraindicated because the blood vessels lack the tunica media in a JNA. So we don't do any of that in JNA. Yes, so can you tell me what is this answer? I think there is a lag a little bit because I see the screen from your end in the phone is getting little delayed from the time I am speaking. So it's okay. Anyways, so the middle-aged man presents with the following lesion on the face. There is a history of acne rosacea. This condition is nothing but rhinophyma, also called as potato tumor, seen in elderly, seen in diabetics following acne rosacea. The treatment is laser debridement and skin grafting. So you will have to do laser debridement of this tissue. Along with that, you have to do a skin grafting. So this is about the rhinophyma. Now, a 70-year-old male presents with neck nodes. Examination shows dull tympanic membrane and deafness and tinnitus. On examination, B type of a graph. Most probable diagnosis is. Yes, Shivam right, Irshad right, Raghunath Sindhu, very good. So when you have a old age patient presenting to you with neck nodes and unilateral B type of graph suggesting to you of fluid or effusion in the middle ear, whenever there is a unilateral SOM in a old aged patients also having neck nodes, there is only one diagnosis that should come to your mind. It is nothing but your nasopharyngeal carcinoma. This nasopharyngeal carcinoma most commonly originates from the fossa of Rosenmuller, and after originating from the fossa of Rosenmuller, it compresses the eustachian tubal opening and it will result in SOM. So whenever you have NPC, you must think about fluid in the middle ear. And how do you know fluid in the middle ear? B type of a graph. Okay, what is Dolman's procedure done for? Meckel's diverticulum, Zenker's diverticulum, Boctolac's hernia, Mehenry's disease. So there is only one ENT diagnosis over here. So I think this can be the most easiest question. The rest of them are all your general surgery questions, general surgery options. So it should become very easy for all of you. What is Dolman's procedure done for? I am waiting for your answers. Yes, so Dolman's procedure, absolutely right. I can see all of you are answering this absolutely right. It is done for Zenker's diverticulum, where you remove this partition which is there between the sac and the esophagus and make both of them continuous with each other, so that food, even if goes into the sac, will ultimately enter into the esophagus. This procedure is called as Dolman's procedure, done for Zenker's diverticulum. Meckel's diverticulum is a true diverticulum. Zenker's diverticulum is a false diverticulum. Meckel's diverticulum is nothing but the omphallomesenteric duct. If it persists, it results in this Meckel's diverticulum. I will not go into details of the rest of them because they are anyways not related to the ENT part. All the following organisms can cause croup except parainfluenza 1, parainfluenza type 2, rhinovirus, Haemophilus influenza virus. Sorry, Haemophilus influenza, not virus. By mistake I said it. So all of the following can cause croup except. What is croup? It is nothing but your laryngotracheobronchitis. So laryngotracheobronchitis is your croup. This is caused by bacterial infections or viral infections, commonly caused by viral infection. Which viruses are responsible for causing this? Most commonly, it is parainfluenza type 1 and type 2. Can rhinovirus cause? Yes. But Haemophilus influenza is a bacteria. It is not a virus. So all of them can cause except Haemophilus influenza. Now typically this infection or croup viral infection occurs in younger age group between 3 months to 3 years of age, presents to you with biphasic stridor, and these children typically on an x-ray will see a sign which we call it as steeple sign. Anyways, we have this x-ray later, so I'm not going to discuss, and the sign is called as steeple sign. The point to take home is it's caused by virus, most commonly by these two, but can the other virus also cause? Yes, except is Haemophilus influenza because it's a bacterial infection. Haemophilus influenza is known to cause epiglottitis and not croup. Okay. The image shown shows a procedure. What is this procedure? Is this endotracheal intubation? Is this needle cricothyrotomy? Is this tracheostomy, or is this oropharyngeal airway? A very, very simple, easy question, which I'm sure you must have seen at least one in your wards, or once in your, whenever you were exposed to any patient who is in an ICU setting, especially on prolonged ventilation. What is this? What is this procedure? Here you see that there is an opening that has been made in the neck and a tube has been inserted through it, and over that there is a ventilatory or there is a machine that through this the patient is getting ventilated. So what do you think is this? Yes, very, very good. The patient is having a tracheostomy. So typically tracheostomy is making a surgical opening in the neck into the cervical trachea between the third and the fourth tracheal ring. So which rings are we opening? Third and fourth tracheal ring. So if I go above the, you can also go between second and third, or third to fourth, but if you go above second, it is high tracheostomy, and below fourth it is called as low tracheostomy. Endotracheal intubation is again an emergency airway procedure where you do a laryngoscopy and you insert through the mouth a endotracheal tube into the trachea. So a tube is inserted per oral into the trachea, that is your endotracheal tube. Now if there is a patient where you cannot intubate, cannot ventilate type of a situation where the endotracheal intubation cannot be possible, either because mouth opening is restricted or there is a foreign body in the supraglottis, in that situation you will do a needle cricothyrotomy. So this is the marking for your thyroid cartilage, this is the marking for the cricoid cartilage. So at the lower border of the thyroid cartilage and between the thyroid and the cricoid cartilage there exists a membrane. This membrane is your cricothyroid membrane. So you take a needle, a 14G needle, and insert it there and connect this 14G needle to an oxygen cannula to help ventilate the patient until you have done a proper tracheostomy. Oropharyngeal airway looks something like this, where you have to put the Goodell's airway in the mouth for bag mask ventilation. This is nothing but your tracheoesophageal prosthesis used in patients with total laryngectomy. So this is your tracheostomy, or a permanent opening in the posterior wall of trachea. You are seeing there is a prosthesis. This is called as tracheoesophageal prosthesis. So I think all the airway procedures in one go you should be able to recognize if any of these IBQs are given in the exam. All of the following, which of the following can cause a sensory neural hearing loss? Labyrinthitis, otosclerosis, wax, or CSOM? So which of the following can cause a SN loss? Yes, I am waiting for your answers. Yes, so when we see otosclerosis, it is a condition where there is excessive deposition of otosclerotic focus or spongy bone, excessive deposition of bone around the foot plate of stapes. So when there is a deposition of bone around the foot plate of stapes, what type of hearing loss will you get? You will get a conductive hearing loss. Ear wax is an external ear abnormality, so again a conductive hearing loss. CSOM, a middle ear abnormality, this also will result in conductive hearing loss. Labyrinthitis is inflammation of inner ear, so inner ear disease will result in sensory neural hearing loss. Okay. So Campylobacter cricothyroid membrane lies somewhere between your somewhere between C3 to C6. So we cannot tell exactly at what level, somewhere between lower border of C3 and between C4, around that area you will have the cricothyroid membrane. Okay. Okay, so this was about the question. Now the next question, a 40-year-old female presented with a history of discomfort while swallowing the food. She has no history of fever, sore throat or smoking, but has a history of Marfan's in the father. On examination, there is a unilateral swelling of the tonsil with pulsation. What is the most likely diagnosis? Very easy question. So presenting to you with difficulty in swallowing the food and there is a pulsatile swelling. I'll give you a clue. What blood vessel lies lateral to the carotid? If you know that, you will know the answer. So which blood vessel lies lateral to the carotid? So the blood vessel that lies lateral to the carotid is your lateral to your tonsil is your internal carotid artery, and this internal carotid artery, if there is a medialization, or if there is a patient like Marfan's in whom you can expect aneurysm or abnormalities of the blood vessel, you will have the pulsations from the carotid going to the tonsil, causing bulge of the tonsil and pulsation of the tonsil, which is exactly what is happening in this patient. So this definitely has to be your ICA. Even if you do not know ICA is located around the tonsil, you at least know that the lesion that we are talking is oropharynx, which is extracranial. So you will rule out the intracranial pathologies. Now extracranial, the only option that fits best to our knowledge is going to be the extracranial internal carotid artery aneurysm. External carotid aneurysm is not going to present as a swelling or a pulsation from the tonsil because it's present quite lateral in the neck. So if you see, this is your common carotid artery. This common carotid artery is going to give rise to two arteries. This is your internal carotid artery, which is very close to the tonsil and can be medialized also. Lateral will be your external carotid artery. It is very far from the tonsil. So whenever you see that pulsations from the tonsils come, it is via the ICA. But is tonsil supplied by ICA? No. Tonsil is supplied by your external carotid artery circulation. ECA supplies it, but what is close to the tonsil, it is your ICA. Okay, clear? Okay. So that was your 2020 questions of the two sessions. Now 19 and 18 we are just going to do very briefly, very quickly, so that you have an idea of these questions, although not very important, but at least you should know the important topics that are there in these last 2 years of 19 and 18. Now, which muscle is required to open the eustachian tube? Is it tensor veli palatini, salpingopharyngeus, tensor tympani, or palatopharyngeus? So basically eustachian tube is a tube that connects the nasopharynx with that of the middle ear. Now this eustachian tube is normally a collapsed structure. It's not open like that. It's always collapsed. There are two muscles which will actively open the eustachian tube. Which are those two muscles which open the eustachian tube? The two muscles which are eustachian tubal openers are... Excellent, all of you have answered it right. The two muscles which are eustachian tubal openers are tensor veli palatini and levator veli palatini. Very good, Keshri. Very good, Mahendra. Mahendra, not, I mean, it's not C, it is veli palatini, not tympani. Okay, rest of you, Raj, Ranu, very good. The answer is tensor veli palatini muscle. Okay, so the muscle which helps in opening are two, tensor veli palatini and levator veli palatini, which are nothing but your palatal muscles which will help in opening the eustachian tube. Okay, a patient who recently got denture fixed was found with an oral thrush. Now if you hear the word thrush, you should know what we are talking of. Vaginal thrush, oral thrush, esophageal thrush. There is one important organism which will cause this condition. What is that organism which will cause this condition? Is it diphtheria? Is this candida? Is this streptococcus mutans or staphylococcus aureus? Again, a very easy question. Whenever you have a foreign body, or especially in old or especially diabetics, in poor orodental hygiene, we see this whitish patch, a whitish thrush. The answer should be candida, and I see all of you have answered this right. Absolutely right. So the answer is candida. Diphtheria presents to you as a white continuous patch. It is not discontinuous ulcer like this. Continuous patch which goes from the tonsil to the palate to the hypopharynx to the larynx, and it is not pearly white like this. It is dirty white or greyish white. There will be associated bull neck also. Streptococcus and staphylococcus will not cause this whitish lesion. They will cause reddish lesion or reddish discoloration and ulcers. Okay, now let's go to the next question. A lady comes to OPD after having a fall from her scooty. Her vitals are stable. She is having continuous clear watery discharge after 2 days. So fall and nasal discharge which is clear and watery. This is most likely a feature of CSF rhinorrhea, acute upper respiratory tract infection, middle cranial fossa fracture, or simple rhinitis. Now for URTI or rhinitis, do you think there should be any history of trauma or fall to cause that rhinitis? So we of course will rule this out, right? Yes. So what is the answer? Middle cranial fossa fracture, will it present to you with CSF rhinorrhea? Very rarely. Only if there is a CSF otorrhea via the eustachian tube can present to you with paradoxical CSF rhinorrhea. But this is very rare. CSF rhinorrhea because of trauma to the anterior cranial fossa is a more common occurrence. Very good all of you. The answer is CSF rhinorrhea. Now whenever there is a prakhar, you're asking me how to differentiate CSF rhinorrhea from URTI. There are many tests, but quickly I'll tell you. The first test is your handkerchief sign. So in your handkerchief, if you take that fluid that comes out from the nose, and if you see stiffening, it is nasal fluid because of respiratory infection. If there is no stiffening, then it is CSF. That is your first sign. The second sign, you can send the fluid for analysis. Okay, so when you send the fluid for analysis, you can see glucose concentration. That will help you determine. CSF contains 2/3 of your blood glucose, but if it is less than 2/3 of the blood glucose, then it is not CSF, it is your nasal fluid. The next thing is you can do is ask the patient to bend forward. On bending forward, normally if it is your nasal secretion, if you do this, you can sniff back. So sniffing is possible, sniff test is positive, or you can sniff back if it is nasal secretion. CSF cannot be sniffed back. But all of this are all not definitely diagnostic test. The diagnostic test that will tell you is beta 2 transferrin. Beta 2 transferrin is the investigation of choice to understand is it CSF or it is nasal fluid. Got it? I hope all of you got this question. Okay, last question. How are you differentiating diphtheria from candida? That was your question. Okay, so basically whenever there is a denture, why would you think about diphtheria to be a cause? But whenever there is an infection, like say URTI, or the history is that of a child, or if there is a history that it bleeds on scraping, you will not think of of course you can think of diphtheria because diphtheria also bleeds on scraping, but here you are seeing the ulcers or the lesions are not continuous with one another, they're discontinuous with one another. But in diphtheria you will see a constant white patch. That will tell you. Along with that, the history will be very typical. A 8-year boy, bull neck, toxic feature, cervical adenopathy, continuous whitish plaque on the tonsil. All of that will tell you about diphtheria. But here, since they're talking to you of a foreign body, a denture, the first time maybe the patient has got a denture done and the patient is not maintaining hygiene. Hygiene is related to thrush, so you should think about candida, and the word thrush is used pointing you towards candida. Okay, great. Now office headache is due to inflammation of which sinus? Frontal, maxillary, ethmoid, or sphenoid? A very easy question. Office headache, morning headache. What is this office headache? So it occurs due to inflammation of which sinus? Does it occur due to inflammation of the frontal sinus, maxillary sinus, ethmoidal sinus, or sphenoidal sinus? So this is something that you see in office headache, is something that you see in frontal sinusitis. So when the patient is in the supine position like this, when the patient is sleeping in the supine position, in the sleep, what is happening? There is a retention of secretions in the frontal sinus because it is in the anti-gravity position. So there is retention of secretion. Now when the patient wakes up in the morning, what is happening? The entire sinus is full of pus, and morning the patient will have headache. So on waking up, there is severe headache. But as the day progresses, what will happen by the evening? The discharge will go and get drained by gravity. So there's a gravity dependent drainage, and evening the headache is relieved. So the headache becomes better. So headache that gets better by evening, more in the morning when the patient has to go to office, we call it as frontal headache. This is also called as periodicity. So periodicity or periodic headache, office headache, is a feature of frontal sinusitis. Maxillary sinusitis will not have any of this. They'll complain to you of pain on the cheek, ethmoidal in between the eyes, and sphenoidal sinusitis on the vertex or occiput. Okay. Now, the most prominent projection that you see in males is that of the Adam's apple. So, this Adam's apple in male is due to what cartilage? Is it the thyroid? Is it the cricoid? Is it the hyoid? Or is it the epiglottis? So, if I take the neck of any male, you will see something that's very prominent in the neck that lies below the hyoid bone. What is this most prominent projection that lies below the level of hyoid bone, which meets at an angle of 90 degrees in males and 120 degrees in females? What is that cartilage? Yes, very good. The answer is thyroid cartilage. Below the thyroid you have the cricoid, and below the cricoid what do you have? You have the tracheal rings. So I hope this is clear. What is this membrane connecting the thyroid cartilage to the hyoid bone? What will we call this membrane as? Thyrohyoid membrane. Between the cricoid and the thyroid, cricothyroid membrane, and between the cricoid and the trachea, cricotracheal membrane. So the Adam's apple in males is due to thyroid cartilage ala. This meets at an angle of 90 degrees in males and 120 degrees in females. Okay, the most prominent and the larger air cell of the ethmoid sinus. So they're asking you largest, biggest air cell of the ethmoid sinus. Which is that biggest air cell in your ethmoid sinus? Quick guys. I know all of you know this. So ethmoidal air cells are sandwiched between the frontal sinus anteriorly and your sphenoid sinus posteriorly. And you have a first cell, the anterior most cell, or the first cell is called as, very good, everyone is answering it right, this is called as agar nasi. Behind that you have the big ethmoidal air cell. This biggest ethmoidal air cell is called as bulla ethmoidalis. Now we have a posterior ethmoidal air cell that can extend into the sphenoid sinus. Normally they should stop right at the anterior wall of sphenoid, but if you have a posterior ethmoidal cell extending into sphenoid sinus, what will you call that cell as? You will call that cell as Onodi cell. So Onodi cell is a posterior ethmoidal cell extending into the sphenoid sinus, and a cell that is present inferior to the orbit and medial to the orbit. So if there is an infraorbital cell, you will call this as a Haller cell. So the question is asking you which is the biggest or the largest. The answer will be bulla ethmoidalis. Great. Now, what is the most common presentation of a patient with nasopharyngeal carcinoma? Is it neck lymph node? Is it blockage of the nose? Is it loss of smell or blood tinged nasal discharge? Again, a very easy question. So, what is the commonest mode of presentation? So if I take the nasopharynx, this is the eustachian tubal opening, this is your torus tubarius, and this is your fossa of Rosenmuller. Now we have the carcinoma coming from the fossa of Rosenmuller most commonly. So if I have a carcinoma that is originating from the fossa of Rosenmuller, and if it is small like this, is it causing nasal obstruction? No. Is it causing eustachian tubal obstruction? No. Is it causing any of bleeding symptoms? No. Is it going to cause cranial nerve palsy when the tumor is small like this? No. But do we know nasopharynx is rich in lymphatics? Yes. So can there be lymphatic spread to the retropharyngeal node and from there to the cervical nodes? Yes, so the most common presentation is neck lymph nodes or cervical lymphadenopathy. That is the most common mode of presentation for early tumors. Now, advanced tumors can present to you with bleeding, with eustachian tubal obstruction, with cranial nerve palsies, all of that. But when the tumor is small, what will happen? First presentation will be cervical lymphadenopathy. So the most common presentation is cervical lymphadenopathy, especially in a triad which is called as, it is seen in a triangle which is called as Hose triangle. Hose triangle is medial end of clavicle, lateral end of clavicle, junction of neck and shoulder. We call this triangle as Hose triangle. So in this triangle you will most commonly have cervical lymphadenopathy. Now, EBV is associated with which carcinoma? A very common question that we commonly see in the exam. EBV is seen in association with which carcinoma? Epstein-Barr virus is typically known to cause one of the most common ENT malignancies, and like I see, most of you have answered it very correctly. The answer is nasopharyngeal carcinoma. So Epstein-Barr virus is associated with nasopharyngeal carcinoma. Okay, the next question. The investigation used for CSF rhinorrhea are all except. So all the investigations given are used for CSF rhinorrhea except one. Which is that one investigation which is not used for CSF rhinorrhea? Is it CT cysternogram? Is it X-ray skull, beta-2 transferrin, or HRCT? Not used except question. Yes, very good. All of you absolutely right. So the investigation not used is going to be an X-ray skull. Now CT cysternography is used for patients with active CSF leaks. So we do a lumbar puncture and we insert fluorescent dye through the lumbar puncture that goes and stains the entire CSF. Now after that, if I take a CT scan, I can track that fluorescent dye through the defect and it is coming into the nose or not. So that investigation will tell us active CSF leak is your CT cysternography. Beta-2 transferrin is the investigation of choice to understand whether this fluid coming out of the nose is CSF or not. So that is the investigation of choice. HRCT will tell you bony defect. So wherever there is a bony defect, presence or absence of bony defect is understood by HRCT temporal bone. So I think there is a lag. Just give me 1 second, it will get fixed. Okay, so this investigation that is used for diagnosing CSF rhinorrhea are all except simple X-ray will not show you any defect. It's very hard to make out defect on a simple X-ray. Okay. Treatment of choice in early nasopharyngeal carcinoma is chemotherapy, radiotherapy, chemo and surgery, surgery. So what is the treatment of choice for early NPC? So nasopharyngeal carcinoma is a tumor that occurs in the fossa of Rosenmuller, and for early stage lesions, because this area is in an area that is rich in lymphatics, surrounded by bony structures, it is very difficult to do any surgical resections in this area. Yes, so the treatment of choice for early nasopharyngeal carcinoma is going to be radiation therapy. So for all early lesions, it is going to be radiation therapy. So early NPC, the treatment of choice is RT. But for advanced lesions, the treatment of choice is going to be chemo RT. So for advanced lesions, it's going to be chemo RT. If the patient comes to you with recurrence, then the treatment will be surgery. Okay. A 6-year-old boy came to the hospital with complaints of sore throat and difficulty in swallowing. His tonsils were pushed medially. What will be the diagnosis? Is it a peritonsillar abscess, retropharyngeal abscess, Ludwig's angina, or prevertebral abscess? Yes. Good, Shashikanta Sahu, Ranu, Chaurasia, very good. So whenever you get unilateral enlargement of tonsil, or whenever you get a unilateral bulge of tonsil, there is going to be two differential diagnoses that you should understand. The two differential diagnosis is either going to be a peritonsillar abscess or either it is going to be a parapharyngeal abscess. So in peritonsillar abscess there will be no neck swelling, but in parapharyngeal abscess there will be a neck swelling. So unilateral bulge of tonsil with a neck swelling, your answer should be parapharyngeal abscess. No neck swelling, you should think about a peritonsillar abscess. I think this is a very common repeat, and I see some of you have answered it right. Prakhar Gaming, you have answered it wrong. The answer is going to be A, that is nothing but your peritonsillar abscess. Okay, so with this we stop the class for now. There is 2018 questions as well. 19 and 20 we have completed, but there is some lagging issue. But for that matter, anyways, my I don't know what's the reason. Intermittently, every 45 minutes or 1 hour, there is some 1 or 2 minutes of lag. But I hopefully it should get resolved, and I will do the rest of the question. Rest of the questions we will do it tomorrow, where I will be doing 22 and 21 in the priority, so that your last 4 years ka complete ho jayega, and 18 we will do it at the end. Okay, so Paras Sen, you are on PrepLadder platform and I teach ENT on the PrepLadder platform only. Okay. Great. So I think I'll take your leave for now. I hope you guys enjoyed the class here. You understood about many of the important things, and most of all, the point that I had to drive to you in your head was about carcinoma of the larynx, and I hope I did that. And I'll see you again tomorrow at 5 p.m. Hope to see all of you tomorrow again, and wishing you good luck and happy studying. Take care and bye-bye.